Everyone. I think it's time. My name is Anafi. I'm from ASLM, and I'll be your moderator for the session today. Maybe I may start by saying what started as a mystery disease, first referred to as 2019 novel coronavirus, and then later named COVID-19, is, according to latest statistics by WHO, I must say maybe as of yesterday, we have reached a total of over 372,000 confirmed cases, of which about 39,800 were in the last 24 hours. We also know that about 16,200 deaths have already been recorded, of which just over 1,700 in the last 24 hours have been seen. And indeed, this is a difficult period for the world globally. In other words, we could say this is a war against this coronavirus. In the same period, though the pandemic is really reaching Africa with just about 1,305 confirmed cases as of last night and about 26 deaths, we need really to pull up our socks as well. So by way of background, I must say by 30 January 2020, when the 2019 coronavirus outbreak was declared a public health emergency of international concern, the Africa CDC trained member states on laboratory detection of the coronavirus. After the training, members were provided with some test kits for detection of cases in their country. And we are saying, understanding this critical role of laboratories in surveillance for early detection, as well as confirming these cases, is actually timely for us. And laboratories are actually urged to adhere to quality laboratory testing, quality data management, as well as the reporting of these effectively for us to be in a state of preparedness. So underscoring this urgent need really for access to accurate and standardized diagnostics for the SARS-CoV-2, which is the causative agent of COVID-19, ASLM and partners, NICD, Korea, World Bank, Africa CDC, IQVIA, decided to host this special eco session on laboratory diagnosis of COVID. The session will actually address challenges that these testing laboratories are facing, those particularly that were trained to detect the COVID. The WhatsApp group of these laboratories is reporting so many questions regarding instrument setup and related issues. So we have therefore decided to bring in subject matter experts from people who use instruments, as well from our colleagues from the manufacturers, Roche, Thermo Fisher, Biomiro, Biorad, etc., to be able to help us answer some of these questions that are in there. So today's session will really be, we had planned for 1 hour, but realizing that this could actually go longer, we are happy to extend with 30 minutes. Hopefully, those that can be available can stay on. The presentation will be about 20 to 25 minutes, followed by a discussion session. That will take us into that Q&A. As the session goes on, by way of logistics, we kindly ask you to enter into the chat box. I'm glad some of you have already started. You enter your name, your organization, and if you are more than one behind the screen, just kindly enter the names of your colleagues as well as organization as well. Please kindly mute your mic if you are not speaking. Today, I'm honored to introduce our presenter from NICD, Dr. Jinal Bhiman, who is the director of the National Influenza Centre based within the Centre for Respiratory Diseases and Meningitis, CRDM, at the National Institute of Communicable Diseases, NICD, South Africa. For the past 10 years, Dr. Jinal's research has focused mostly on HIV vaccine development with the aim of exploiting viral evolution to inform vaccine design through reverse vaccinology, viral-centric vaccinology, and a combination of both. For a junior investigator, 4 years post her PhD, she is widely cited, an amazing 1,348 sites with an H index of 10, and has authored and co-authored seminal works in HIV vaccine. In her current research in the respiratory pathogen field, which we are focusing on today, her specific focus has been viral pathogens, namely influenza, the RSV, as well as the SARS-CoV-2. She is directly involved in influenza surveillance, serology. Additionally, the CRDM houses a WHO RSV's reference lab, and Jinal is part of a WHO RSV scientific working group that aims to standardize RSV nomenclature. Finally, she is the SARS-CoV-2 lab lead on assay development and implementation. As well, and she has led the rapid setup of verification of an in-house test for the detection of COVID-2 at NICD. She continues to provide expert advice to WHO Lab Diagnostic Group, and she is the deputy lead of the NICD Department of Health Incident and Structure. Ladies and gentlemen, I'm honored to introduce Dr. Jinal, who is going to take us through a 20 to 25-minute presentation. Thereafter, we have our question and answer. Dr. Jinal, please share your screen and take the floor.
Thank you, Anafi, for that wonderful, wonderful introduction, which is kind of intimidating, actually. Just sharing my screen. So, my presentation is actually very short. You'll have to forgive me. My time has been very limited, and I tried to compile as much as I could in terms of what data we have from our lab that might be useful. Collins from ASLM also sent me a few questions that came up on the WhatsApp group that I wasn't able to address, and I think some of them are pretty basic and won't require a lot of discussion, but the very last one is something that I think all of us need to consider. But let me just start by reiterating the algorithm that we initially presented to the participants of the Africa CDC training, which was held at the end of February. And this algorithm was based off the Roche kit, which is actually at the Tipmol Bio developed kit. And that was based off the Charité protocol or the Common et al. Paper. So basically, the decision was made that we would screen with the e-gene assay, and the kit comes with an extraction control that you add or you spike into your sample. Very easily, if it comes back as negative, then that's easy. But the advice was that if the clinician suspects that, you know, something may have gone awry or that this person might be in the early phases of infection, then they should send through a repeat specimen. And of course, if the sample quality was low, they should send through a repeat specimen. On the next little outcome was if the extraction control was negative, the result would be inconclusive and you would definitely need to collect a second specimen. Because it would basically mean something failed there, and also you would probably repeat your test. However, if you got a positive result, you would then perform a confirmation assay using the RDRP gene primers and probes. And if that came back positive, that would be then actioned as a confirmed case. If this gene came back as negative, we would report as indeterminate. And the initial recommendations then were to repeat the test, of course, and in parallel get a different specimen from the clinician. So that was just basically the reporting algorithm. Of course, all your negative template, negative controls and no template controls had to be negative to eliminate any PCR failure or contamination. So then I just thought to summarize some of the results that we have. So this is not all of the data that we have from our positive samples, but it is some. There is a bit of a lag in terms of collating our data and getting it up onto our databases. So I'm only showing here results for 68 samples. And this is looking at the CT value for the E gene. So you can see in the dotted lines here, this is our minimum, the lowest value that we got, and our maximum. And you might be thinking, oh, wait, 39.48, didn't we decide that anything below 39 would be considered positive? And I'll explain this one now. But I just wanted to show you that, you know, there's a nice distribution of CT values between these two. There isn't really any trends with clustering at lower CT values or higher. It is pretty diverse and pretty spread out between these two. So in terms of this very high CT value here, and there is another one next to it as well, but in terms of this one, you know, we repeated the E gene assay, we confirmed on RDRP, and then we're very extra here at CRDM. We tested this on every other kit and our in-house primers that we have. And for all the others, the CT value was pretty high, but was below 39, so we call this as a positive. So this is just to give you an indication of, you know, the fact that you can get things that are kind of outliers and almost on the limit of detection, but that you should scrutinize, you know, and also rather act with caution in these situations. And then on the next slide is just, sorry, I forgot I'm in control. Let me just say on the next slide. So this is now showing the RDRP gene distribution. And again, there's a bit of a lag, so I only have 33 sample values here. But again, it's a similar thing as what's seen with the E gene. There's a nice distribution of CT values. And, you know, what I then did was to compare where we had matched, where I was able to get the matched data for the E and RDRP genes, just to compare how they look, you know, in comparison to each other. And basically, the overall trend is that there is generally 0.7 to 2 CT difference between these two genes, but that the E gene is generally more, you could say, slightly more sensitive. It has generally a lower CT value. It's not a rule. You can see there are many exceptions here where there are examples of the RDRP CT value being lower. And that's just really to give you kind of like a background on what results we've been seeing. So then I wanted to bring up some issues regarding quality of the kits that we're getting, quality of the primers and probes that we're getting. Because as you all know, there's a really extremely high demand for all of these reagents globally. And so, you know, the quality is of concern, because basically companies are churning these out as quickly as possible. And unfortunately, the high quality that is generally expected is not being maintained. So our recommendation for primers and probes is, you know, once you receive them and you resuspend and dilute, to aliquot immediately for enough for one run. So that obviously is dependent on how many samples your lab is processing at the moment. But we're currently aiming to aliquot for one full plate. If you're running a few less, then obviously aliquot for less. The other issue that you should be aware of and keep an eye out for is contamination. So this has been reported by Australia, by multiple countries in Europe, Hong Kong, and the US, that they have been picking up false positives due to contamination of the primers and probes. And it's very easy to pick this up because your no template control will come up, but just to be aware of it and just to be, you know, extra vigilant and make sure you check all your controls for every run, even when you're in a situation where you are inundated with samples. Then some other topics that I wanted to bring up is that when you get to a case or when you get to a point in time which South African labs can attest to, where you are drowning and you have so many samples you don't know what to do with yourself, it might be better to use a multiplex kit or to develop a multiplex in-house assay. It just means that you reduce your workload. You know, you test your sample once and then you've got your screening and confirmation all done. We're currently trying to develop our own in-house assay for this, and if we get it to work, we are more than willing to share sequences and protocols with everybody on the call. And the reason for this relates to point number 2 on the slide, which is, again, you know, reiterating that the stocks are really short and the companies can't keep up with how much they need to produce. Currently, in terms of our own experience, we have no real guarantee for when we might receive kits from the US and Europe. There are some options available from China, but obviously it hasn't been confirmed yet. And so this is also coming back to this in-house assay setup. If at all possible, I think everyone should be trying to aim for this, especially if you can get primers and probes and your enzyme locally sourced, or at least sourced from other African companies. Because, you know, there's just huge now issues apart from supply in terms of transportation, with everybody having travel restrictions implemented. It's really, and having lockdowns, it's really impacting transport of reagents. So if you have the time, if you have the resources to try and set these kind of in-house assays up, that would be our recommendation to you. That's a huge issue that we are facing right now, and a huge stress that we are concerned with right now. So that was really short. That's pretty much everything I have in terms of our experience so far and what are some of the issues we are facing. So the next part, I'm just going to go through the very short short list of questions that I received from the WhatsApp group. So this is not really even necessarily useful to everyone, but I think this one might be, in case some people don't pick this up from the WHO guidance, but it's just a question about, you know, when do you discharge somebody? According to WHO, they must be PCR negative on 2 subsequent tests done on different days and from samples taken on different days. But the advice is that upon discharge, they must still self-isolate for 14 days because, you know, they could still be shedding virus and that kind of thing. The second question was about the reconstitution. So from the Africa CDC training, everyone got sent home this lyophilized enzyme. And we did send everybody home with the instruction manual, but I don't know if it's just not clear, or if I have had this question a lot of times actually, how to reconstitute the enzyme. It's very simple. So in the little packages, there are 4 tubes. 2 of them contain the lyophilized enzyme beads, and the other 2 contain the reconstitution buffer. You simply add 1 reconstitution buffer into the lyophilized beads. Mix it with your pipette, don't vortex, and it's ready to go. But yeah, I got this question a lot, so I thought it's better to just address it here for everybody. And then this was a question that I do not have an answer for, and that was in terms of copy number of the controls for the terminal kit. I have contacted them, I have emailed them. If and when I get an update, I will obviously let you all know. So then just to go on to the final question. So my presentation is really short, as you guys can see, but I think that's okay. I think that we should make the most of our time in terms of what questions you might have. But in terms of WHO recommendations, this I think is really important now, because everybody is going to be entering a phase where they have a lot of samples to test and where they're getting community transmission. And so WHO recommendations state that in this situation, you should probably aim to just call a positive by 1 target and not have to do screening and then confirmation. And it's simply because of workload, like you just can't cope otherwise. And so that brings us to these 2 questions, which I just combined here. I'm not going to really read them, but they both, to me, the way I interpreted them, they were both asking, you know, if one gene target comes up positive and another one comes up negative, what do we do? Okay, so firstly, in terms of, is there an explanation? I have no explanation. So we've seen this happen now with a number of samples where, for example, only the N gene would come up, even though the N gene is not something that the WHO kit makes use of. Obviously, we've been doing everything we possibly can. The N gene would come up and nothing else would come up. In other instances, we've had the E gene come up and nothing else come up. So yeah, I would like to say I had an explanation, but I don't have an explanation at all. What we have noticed in terms of the N gene coming up alone is it seems to be when people test positive, and then we've obviously been testing them for a couple of days after they test positive, to see when they become negative. And it seems to be that towards the end of that infection phase, that acute infection phase, only the N gene is coming up and the other two are not. But yeah, but that's not a rule again. It's just something we've noticed. And so basically what we've decided in our lab is that irrespective of whether we get 1 gene, 2 genes, or 3 genes coming up, we will action it as a positive so that, sorry, hang on one second. So we have been confirming it. We have been confirming with other commercial kits. But in terms of the labs who don't have those resources, so if you're sitting in a situation where you just received the WHO kit and you don't have another kit with which to test, our advice would be to call it a positive and get the public health action going, get that person in self-isolation or quarantine or whatever the issue is, because it's better to act with extra caution and try and limit the spread as much as possible. And I think this is something that maybe we should all discuss if other people have concerns about, using this kind of approach, or if other people agree that this is something we should do. I think this is really the most important question that came out of the WhatsApp group, for me in any case, because it really does have huge consequences if you don't call something as positive, and then it was. So I'm now going to just hand over back to Anafi, and I think we can open up the floor for questions. I think it would be much more useful if people actually have real issues that they want to bring up. It's much easier to communicate like this way than on WhatsApp, to be honest. So Anafi, I'll hand back to you.
All right. Thank you very much, Jinal, for the presentation. We appreciate your availability given the circumstances. So we are about to get into a question and answer segment. I must say, thank you for the overwhelming participation. We know today's session is a little bit technical, as this is more of a follow-up on really the training that was done a couple of weeks ago. But we have also planned for a session on general diagnostics coming on the 30th, so stay tuned as well. So getting into the question and answer, I'm already seeing questions in the chat. Please enter your questions or comments in the chat as we go on. And we are about to take the first question, which came from Aileen Bear. Hi, Aileen. She says, hi, everyone. Do we have any data on what protocols and technologies that are being used across the African Union? Do we have data on what protocols and technologies that are used across the African Union? Hello, Jinal, are you there?
Sorry, I'm not sure about data. I don't think we have access to everybody's data. And I can't confirm, I can't speak for every single country. I know of the countries that were trained by Africa CDC. Most of us are using the TIP-Mobile kit or protocol, which is actually the common protocol. But in terms of South Africa, many of us are using the C-Gene kit, purely because it is a multiplex assay, and it's actually really lovely. It's straightforward. You plug it into your machine, it gives you your results. It's really very easy and very lovely. And if you have a lot of samples, it just simplifies your life. The other kit that people are using here in South Africa is from Thermo Fisher. It's the version 2 kit, which is also multiplexed. Both c-gene and thermo test 3 different genes in one reaction. We are also looking at BGI, which is a Chinese company, and Beijing Genomics Institute, that's what it stands for. And they have a kit that only tests for one target, but they seem, well, certainly in South Africa, there seems to be some ability for us to access these, given the current lockdown situation that is going to be starting tomorrow. And then I'm trying to think what else we've tested a few other kits, but they weren't particularly good, so I'm not going to mention their names. And then we've also set up in-house assays using primers and probes from Nkaba Biotech. I know I said it wrong, I apologize. And one thing to note about their primers and probes is they are a little bit unstable. So yeah, just do what I said, and when you reconstitute and dilute, just aliquot for how many runs, for as many as one run will contain, and then avoid freeze thaw cycles. And yeah, in terms of enzymes, locally sourced enzymes, we're still looking into that. We haven't tested any yet, but that's definitely on our priority list given the stock concerns. I don't know if anyone else from any other countries would like to comment.
Thank you, Jinal. Yes, I think maybe, I don't know whether our colleagues from African Union, Linda and Tim. Okay. Yeah. So
and I think this is Enio.
Please, Enio, please go ahead.
Yeah. So as Jinal explained, most countries are using the TIB mole biol kit, but I think starting this week, we are also shipping, large number of test kits from this Ethiopian Prime Minister Jack Ma Foundation initiative. That will be a Chinese kit. I think it's included in the WHO emergency use list already. So I'm not sure about performance. It has been, extensively used in China. But I would like to hear, the feedback from the lab community, how that looks like when they start working on that. But generally, so far, it has been, the German kit that's mostly used by many countries. So Africa CDC distribute more than 75,000 tests on that test kit. Thank you.
Thank you, Yenu. Eileen, I hope that has been answered. And I think Jinal might have partially also answered your next question, which is talking about where are you buying these primers from? I think you touched a bit. Do you want to add a little bit, Jinal, or anyone, Yenu as well? The next question was, where are you buying these primers from?
I think the common source of primers, this is Moyo, the common source of primers is Inhouse Biotech in South Africa. They are very fast and very cheap primers. Inhouse Biotech, IQVIA Biotech, you could check with them. That's where we order primers. My question while I'm still there is, I think many countries will be receiving this BGI kit, and which has only one target. I still worry that in this early phase of the epidemic, although we want to call as early signal of a positive, we might have a situation of over-reporting, and in a pandemic, we want to make sure that that you avoid that. I don't know what other countries' experiences are, but I think it's something that we're worrying about. And if anyone has this kit, we know that is on the way, and we have been looking online for the packaging set for the BGI kit. The other kits that have more than one target are more preferred because they're more cross-reactivity between COVID-2 and other coronaviruses in terms of the target. So if you have a screening and you don't have confirmatory, what's the sensitivity of that? We don't know.
No, I think to clarify on that, it has both screening and confirmatory. for this kit as well. I think the screening is the N gene, confirmatory is ORF LAB1. So this is not, you know, one target.
Do you have the package?
Sorry, just to confirm, there's two versions of the BGI kit. The initial version only has one target. So for example, they've sent quite a few kits to us, and it's the kit which only has one target. And I think the second version has two targets.
Yeah, this one is with two targets.
So the current one has two targets. Very important contribution indeed. Thank you, Dr. Moyo. I think you have also taken the opportunity and asked the question as well. I think the previous question, I think on primers, I think has been also addressed. So we move to the next. I think the next one is from Margarite, and she says, please indicate which of the WHO recommended assays is presented here. Quality issues common to all. Please indicate which of the WHO recommended assays is presented here. Quality issues common to all.
So the one that I spoke about was the Common et al. Assay, which was developed at the Charité Institute in Germany. And I spoke about that one because that's what we trained on at the Africa CDC training. In terms of the other protocols, the quality issues is not really dependent on the protocol, it's dependent on the reagents. And yes, that is common to all. Just that to be aware of those issues. And not that, you know, every kit you get is going to be bad, but just that it is coming up more and more currently given the speed at which the companies are producing these things for us.
Thank you. Next is about controls. Where do you find positive controls for the in-house tests? And it's from Pascal. Where do you find your positive controls for the in-house tests?
Yeah, so just Jinal, so while you are, thank you, Anafi. And so I would like also to ask, I ask one of my colleague from the Institute of Tropical Medicine in Antwerp to be on the call, because I know that in Belgium they are also developing an in-house test. And that question, as you respond, Jinal, I would also be very interested to understand how, you know, in Belgium and in Europe, you find your positive control. How do you decide, you know, on the primers that you are going to use for your in-house test? So after Jinal responds, dear Leo, if you can chip in a little bit and tell us your experience. Thank you.
So for our assay, which was the Common protocol, we ordered gene constructs way back in January when we didn't know, you know, when there were no kits available. So we ordered these gene constructs and we cloned them into plasmids. That's what we are using currently as controls for the E gene, the N gene, and for the RDRP gene. In terms of if you were thinking of setting up in-house assays with other primers and probes targeting the S or other regions of RF1AB or other regions of the N as well, actually no, ignore that last, just the S and RF1AB. We have had an offer from a group here in South Africa. They're actually a TB lab. That they would be able to make these controls for us in a plasmid form. So I would like to make this offer that if there are labs that are thinking of setting up an in-house assay, we can try and send these controls to you. You know, obviously within our continent of Africa, and also just given the lockdown issues, there might be some complications with transport, but hopefully we can get around that because this is all related to an outbreak situation. And from our experience so far, most things that are related to outbreak seem to be bypassing any regular rules and regulations. So that might be possible. I think that probably would be possible. And yeah, we would like to help if we can in that way.
Thanks, Jinal. I think along the same line of questioning, I know FIND has been doing quite a lot of work, particularly with regards to validation, which also Dr. Moyo has questioned on. I can see Gillian is online. Gillian, are you able to comment?
Sure, thanks very much, Anafi. So FIND is currently working with a group, a cohort of different laboratories to independently validate a lot of the commercial kits that are currently available for PCR testing for COVID-19. We just posted today the list of kits on our website that we're currently evaluating. And as we get data, we will post the analytical sensitivity and the clinical sensitivity and specificity that we find through these independent evaluations, which hopefully should address some of the concerns that people have. We're including the BGI test. I saw a question about the DAN test, or DAAN. So hopefully we'll have some information to share with you all. We're also trying to compile information on various EQA schemes so that as labs roll out either lab developed assays or some of these commercial tests, we can help to ensure high quality testing. And just so everyone's aware, Cassandra Kelly-Serino, who's the head of our emerging threats program at FIND, will be presenting, I believe, next Monday, and we can give a summary of the work we're doing to try to ensure that there's enough data out there for all of your labs to make informed decisions as to what tests you can use.
Okay. Thanks a lot, Gillian, and we are looking forward to that as well. I'm trying to make these questions.
Sorry, Anafi, can I just quickly comment on one thing?
Please go ahead, Renier.
Sorry, it's Renier from Bio-Rad Laboratories. So just addressing the question of the standards or where you can find these standards. So I'm not sure if everyone is aware of this, but we're going to be releasing a set of standards pretty soon. I'm just going to share my screen quickly with you, so I hope you can see it. So the product is from, let me just drag this window so you can actually see it. I hope, can everyone see the screen? It should say Exact Diagnostics. So this is a company that was acquired by Bio-Rad. So we synthesize and manufacture these standards for COVID testing. You can see they contain EN, ORF, RDRP, and S genes as well. And they can be used as both extraction controls as well as for amplification controls. So just for everyone's interest, if you're interested in finding more information, you can go to the exactdiagnostics.com website that I've got here, or you can either just contact one of your Bio-Rad representatives and they'll be able to supply with more information.
Thank you very much, Renier. Very helpful indeed. So moving on, I think you can stop sharing the screen, Renier. Okay, wonderful. I was saying I'll try to take the questions in the order in which they came. I think the next question came from Amha, and I think it was talking about CT values. Is the CT value associated with the viral load? I think that was the question.
I'm not sure if other people can comment on that. We can't comment on that really. We don't know what the viral load is in the samples that we have. So yeah, we can't comment on that.
Yeah, maybe this is open to the floor. Experts on the online. Is the CT value associated with viral load?
Yeah, the cycle threshold value is associated with viral load, but most of these kits, they are doing a qualitative detection of the COVID. So, I mean, the lower the CT value, of course, it means it's a strong positive. The bigger the CT value, it means it's a low positive. And please take care of the threshold that has been, especially when you, is very important between what you call a positive and a negative. So at the moment, the kits are designed for qualitative detection, although with a good standard, there is a way you can get a viral load from there. But to emphasize that at the moment, it's qualitative detection.
Just to add on to that is, you know, it's all dependent on sampling as well. If you've got a poor sample, your CT value might be higher than if you had a sample that was held in somebody's pharynx for long enough, you know. So that's why we're very cautious to say that we don't want to correlate CT value with viral load, you know, unless we have an actual real viral load calculation.
Thank you, Jinal. So the take-home message, I think we need to be cautious there. The next question, I think is, or there's someone on iPhone. Introduce yourself and go ahead, please.
Hi, sorry, apologies, I was on mute, and I struggled to unmute myself. My name is Tina Cresfelder. I'm from Roche Diagnostics.
Please go ahead.
Just a comment on the CT value question is, I agree with what everyone has said here. The CT value and an internal control or a quantitation standard normally both need to be used in order to calculate a concentration, and that would give you a viral load. So because there is no QS per se, just an internal control,
So far, it's been quite good in our hands, comparable to the Tipmol and CG.
Thank you very much.
Yes, I thought now if they are targeting the N, the HORF, and the S protein, the S protein would provide like a complementary test. So I thought it might be a bit specific. So I wanted to hear reaction for those who have already used it.
Thank you, Nzuki.
Hi, this is Alison Glass speaking. I'm the head of the molecular lab at Lancet Laboratories. We've had a very good experience with the Thermo Fisher. We've certainly found it to be one of the more sensitive assays, especially with being able to pick up multiple genes. So we found in the early days where C gene often would only pick up the N gene, and we'd confirm those at that time with the Thermo Fisher. We'd often then pick up N gene and off gene, and would act as a good confirmatory test. So although the throughput is smaller plate numbers with only 30 samples at a time, it's a quick assay, and we found it to be very sensitive.
Thank you very much, Alison, for chiming in, and we appreciate your expertise. Along the same lines, I think the next question is also talking to the same subject, is from Dirie Abdi. He or she says, please mention something about the specificity of the genes, specifically the E gene.
Yes. Hello, everyone. My name is Didier. I work for Thermo Fisher, and I'm responsible for the Eastern Africa region. So my question was basically relating to the genes, because I did saw the first slide that was shared. The screening assay was on the E gene. And then if it's positive, I did see that the confirmatory assay was for the RDRP gene. So I wanted to understand about the specificity in terms of designing of the E protein, basically to do a screening at this particular moment. Is it very specific, or is there any literature that you guys have come across, or is there any experience in terms of specificity of using the E gene as a screening assay at this particular moment? Because this is what I have seen being shared on in the first slide. Please go ahead.
Thank you, Didier. Over to you, Jinal, and then colleagues can chime in.
So I'll comment in the context of the TIPMOL kit, because we have not done extensive validation of multiple kits because we are trying to preserve everything we have for testing samples. So in terms of the TIPMOL kit, the e-gene assay does appear to be, in general, more sensitive than the RDRP and N-gene assays. So as I showed on the PowerPoint presentation, the e-gene has sometimes up to 2-fold lower CT value than RDRP, and actually has up to 5-fold lower CT value than the N. So, you know, with respect to that whole one target coming up thing, in some cases where we saw the e-gene coming up positive, it was a very late positive, so very high CT value. And because the N or the RDRP were less, shall we say, less sensitive, I don't know if that's the right term, they weren't coming up and we weren't detecting them. So I would only feel confident to comment in the context of the TIPMOL kit. I wouldn't be comfortable to compare to other kits because we have not extensively validated multiple kits.
Thank you very much. I hope you have been answered, Nzuki. The next question is from Leon, but I think this has been responded to. Leon, feel free to jump in if that is not correct. I think you are talking about Dan gene, kids donated by JECMA. I think Yenu had responded to that. And I think how the next one then says, how is the BGI real-time performing? How is the real-time BGI performing? Yenu or Jinal, are you able to respond to that?
I'm not able to respond to that yet. We're still testing it against samples. So when we have some more information, I will let the group know.
Okay, thank you. If there's anyone from the group who may want to respond.
I think Anafi, I think this is I think mostly this is a new test kit. I don't think most people in Africa have been using this. Okay. So most likely I think you do, because the good thing is now some of the labs do have other assays as well. So maybe you can even compare. So I think we will. What I know is in China it has been used extensively, and one colleague here, the Chinese scientist here, he says it's a very good test. So I think it's for the labs to check how it performs.
Yeah, thank you. I think we will be learning, I think, as time moves on, and we hope to continue to provide this platform. The next question really has been directed to colleagues from WHO. I hope they are colleagues from WHO online, and this is from Maruping Kinosi Maruping. It says, there is pressure for the lab to use rapid serology tests. What is the position of WHO on this? Do we have any colleagues from WHO online? If not, please, Lara, go ahead.
Hi, Anafi, this is Lara. I would just say, this has been really helpful and interesting. Unfortunately, I don't think we have the key colleagues from WHO online, Mark Perkins in particular, who's leading the COVID-19 response, diagnostics response from the WHO's effort. I think some of the guidance was presented, but I'm not sure. I think it would be ideal to potentially bring him or ensure he's included in the next weeks to respond to some of these questions as our representative there.
Okay, thanks. I know also
it's Fausta here. Thank you, Lara, and thank you, Anafi. I'll just want to add what Lara said, but the initial guidance that we have now is there's not enough evidence as the role in rapid diagnostics for clinical management. So mainly it could be more useful for surveillance, but then this is something that is still under discussion. So at the moment, there is not enough evidence to support use of rapid testing for clinical management.
Okay, Thanks a lot, both. I know there could also be colleagues from CDC online. Earlier on, I saw Clement. I don't know whether you want to comment. Clement, are you there?
Yeah, I'm here. I think at this point, we don't have anything to add on. I agree with Foster and Laura that rapid tests is mostly used, considered for surveillance and not really for clinical management.
Thank you.
So,
thank you.
And if I can comment, this is Enio from Africa CDC. You know, there may not have been evidence so far, but I think it's important that we come up as a lab community on a guidance to member states. I think this is coming from every angle. You know, countries are facing really a real problem in terms of scaling up PCR testing. They are really looking, you know, if rapid tests can somehow be used at least in a form of, you know, surveillance or detecting exposure status or something. Because now we have also, you know, enough positives in Africa, maybe, you know, 2 or 3 labs can do also concurrent test PCR antibody. There are, you know, commercially available antibody tests now, which are CE marked, that are listed on emergency use. So I think as a lab community, we need to come up with some recommendation on that. So countries should not keep us, you know, should not keep continue asking us, you know, what's the role. So I feel that we are a little bit of under pressure to come up with something. Thank you.
You know, just to add that, it would be important if African CDC can lead that and then advise the rest of Africa what to do. So I think hearing from you that I think that's what you would like to see. I think if African CDC can select 3 or so labs that can do that quick evaluation and then make recommendation.
And I feel this is George LMG from OGAG. Thank you so much for this excellent presentation. I strongly hold opinion with the last couple of speakers on the need for this the rapid test. I think there's urge and there's a need for countries to quickly move forward. I know at this point, I think there are 1 or 2 of those serology tests that are actually at the table of FDA for approval, but what we are seeing is that the sensitivity and the specificity are not that very good. So I strongly support the idea that they need to have more evaluations and maybe manufacturers need to think about improving the sensitivity of this. This is going to be very, very helpful sooner rather than later. I remember this was the same issue that we faced during the Ebola outbreak. It was really that difficulty of what can we use, particularly maybe in the form of a serology PCRO combination algorithm to quickly begin to diagnose cases. So I think this is something that we should look into seriously and as soon as possible. Over.
Thank you very much, George. And indeed, I think we know access to testing will be key to us ending this pandemic. So Yenu and Tim, I think we as what is coming from the group, I think we look forward to really pushing this forward as we move on. Talking about the needs for testing within the community, we are trying to have what can I call it? Maybe a simple survey to really check out how can we prioritize. I think what we also put on this platform, and looking at the fact that we have about 6 minutes to the hour, though we are happy to extend with an extra 30 minutes if I think colleagues are there. We are happy to continue for another 30 minutes. So ASLM, working with our colleagues from FIND, we thought maybe we could try and just ask you what is it out there that you want us to really continue to bring on this platform, particularly in terms of COVID trainings and TA. So whilst the discussion is going, I'm going to launch some short survey here on the app. If you are able to respond to it right away as the discussion is going, we would really appreciate. For those that are unable to do so, immediately after the call, we shall send you a link to the survey, and hopefully you can complete it, and then we can inform our future discussions. So you see from your screen, I think something will pop up that you can quickly respond as we move on. Please let me know when you are seeing something on your screen.
Yes, I can see that.
Okay, thank you. So I think you can feel free to respond to that as we move on. The next question really, I think it is moving on to specimens, and it's from Maina M1. And he or she says, what is the lab's experience with the dry swabs? Is there a substitute for VTM or UTM? Maina, feel free to add more details to your question. Maina, are you there? Hello? Maybe colleagues can respond to the question. Is talking about what is the experience with dry swab? Is there a substitute for VTM, UTM?
Sorry, just from outside, dry swabs seem to be okay. We are getting good results from dry swabs as well.
All right, thank you. Any other experiences from other colleagues?
Just one thing, obviously with the dry swabs, you still have to make sure that they're transported within a fast, rapid amount of time, no delays.
Okay. Thank you, Jinal. I'll take on the next question. I know maybe the survey might be sort of distracting you. Apologies for that. But the next question says, we are seeking primers from Sigma Make from Germany. Oh, this one was a response to, I think, the issue of primers. Thanks, Leon, for that. You may want to just add a bit of more info if you want. They're usually cheap and perform well. I think that's clear. Nora from Zimbabwe says, has anyone looked at the new GeneXpert cartridges for COVID-2 that have just been approved for emergency use? I think they will be very useful in decentralization of testing services, given the large footprint in the African countries. That's from Nora. Has anyone started using any GeneXpert yet? Is a question to the group.
Anafi, it's Gwen here, Gwen Stevens from Cepheid, Global Access Team. So I'll just give a bit of clarity on what's happening. So as you're aware, Cepheid has just obtained FDA emergency use approval for the assay, and we've just started manufacturing it. We're planning to ramp up volume significantly, but at this stage we can't provide details about availability and volumes of tests. As an organization, we're working with groups like WHO and FINE to make sure we allocate assays based on the impact they'll have to fight the pandemic. We can't favor one country or region against another. It will be really, a decision we need to make. We need to understand countries' plans to help make those decisions. So, if people are contacting their local Cepheid teams or at a global level, it will help us if countries could provide accurate forecasts on what their needs will be for the assay going forward.
Thank you, Gwen. Thank you.
Just as an information, Anafi, we had also a call with Cepheid, this Africa CDC. We are discussing now. We have the equipment footprint analysis for all African countries, and then we are doing some sort of projection, and then we will share Cepheid with the numbers that we estimated will be relatively accurate for Africa. Of course, we will share that also to member states so that they can also comment on that. Thank you.
Thank you, Yeni. Yes, it's right on top of the hour, but as we explained, we are happy to move on for those that are available. The next question really is a request from Dr. Moyo from Botswana, could you send us the package insert for the BG kit, both versions? I think that's a request that we have. So we'll try to follow up this and get this to you.
Yes, we will send.
Thank you. Next question is from Dr. Maruta. The testing kits that have been donated by Alibaba, are these full kits or part of what is needed for testing?
So these are PCR detection kits. They don't include RNA extraction kit.
Thank you. Okay, you had already responded to that. The next question is, we need help with panels urgently on how can countries get access. We need panels urgently. How can countries get access to these?
Countries can sign up or register for the panel that's being supplied by QCMD. We've registered for that.
Okay, maybe more details. Is that clear to who requested, Moyo?
I can forward maybe the email that we received to you, and you can distribute.
Okay, please, we will forward to us, and then we'll distribute to the team. Next question is from Babika. Hopefully I pronounced this one correctly. I've seen it's also about rapid tests. I think we have dealt with this, but let me go through the question. I've seen COVID-19 rapid test kits at many websites. What are the sensitivities and specificities? What about the window period? And I know Gillian had also touched on this a bit, and we hopefully next week will go deeper into this subject. But I will also open to comments from colleagues. It's about rapid test kits and specificities and sensitivities. I think it has been answered. Not much data is available. Are there any other assays used in comparison to carry out diagnosis? What of labs which cannot afford molecular diagnostics for now and for the future? There's someone who's enjoying. I'll repeat the question from Eunice Omondi. Are there any other assays used in comparison to carry out these diagnostics? What of labs that cannot afford molecular diagnostics in future? Again, I think it's similar to what we have been discussing around rapid tests, but I'll let experts in the group just weigh in as well. All right. Anissa Choika says to everyone, we have been requested to validate tests. What do we need to validate tests? How many samples, positive and negative, do we need to test? And I guess this is also some of the things that we are actually looking out for in the survey that we have sent. But I will also let colleagues from the panel, experts from the panel, to just summarize. Over to you guys.
In terms of from NICD side, you would need a minimum of 30 samples, 10 negative, 20 positive. The 20 positives should have a range of different CT values. But just, while we're speaking about this, if this person is from a lab, diagnostic lab, given the kit shortages, I would recommend that, you kind of push back a little bit and reserve your kits for testing, because validations use up a lot of what you have of your limited stock.
Thank you, Jinal. I know Leo tried to answer this question. Leo, you want to respond? Leo Hendricks, are you there?
Can you hear me now?
Yes, please go ahead.
Okay, sorry. Yes, at IQM we started a couple of weeks ago with it. And for the validation, we received 10 samples from a clinic, blinded samples, 5 of them were positive, 5 of them were negative. we could all correct identify them, but then also we didn't have more samples, so then it's difficult to for a validation. But what we did is that for some of these samples, we repeated 10 times on different runs, different days, to see whether we always had the same result, and that was the case. So that's also a kind of validation you can do, but then of course also you run out of reagents if you don't have enough.
Okay. Thank you very much, Leo. And I also want to drive your attention to the chat box. I think there are also resources, links to the resources that are being provided by colleagues online. And we also compile these and also forward to you by email. You can see resources from FIND, the link for tests that are being evaluated as well. And this is in response to the questions that I had read earlier on. Hilary from Malawi says, considering that this is a centralized type of testing, what are the recommended sample transport conditions, packaging requirements, and PPE for sample transporters? I think this is a very important question from Hilary. Considering that this is a centralized type of testing, what is the recommended type of sample transport condition, its packaging requirements, as well as the personal protective equipment for sample transporters?
I can respond. I'm sitting with Jinal. My name is Mignon. I'm one of the colleagues at NICD. So just in terms of transport, so if it's a dry swab, it can just be sent at ambient temperature. If it's in VTM or UTM, it should go on, not on dry ice, but just on ice packs, so sort of 4, 5, 6 degrees. PPE should not be any different to PPE for any other laboratory specimens. So it does not need to be treated any differently. So however people normally dress, if I can put it that way, that is how they should continue to do so. Many of the pathogens that we work with are far worse than coronavirus. So we should always be practicing a good laboratory practice as far as that's concerned. Over.
Thank you very much. I think the next couple of questions have to do with RDTs. I think we have touched on that, and ACDC also has responded. So I'll jump on to Nonhlanhla Mbene's question. And Nonhlanhla says, we are running short of swabs and VTM. Can we use EMIS gel-based swabs as we have much in stock? What other alternatives can be used?
The gel-based swabs are fine as well.
So Nonhlanhla, there you are. Gels-based swabs are also acceptable. Leon says, we have adapted the WHO TIB kit together with the CDC kit and running the N gene together with the E gene using the RP as extraction control. It is performing well, but the RP has not performed well, as Jinal has mentioned. Thank you, Leon, for sharing the experiences. Okay, next one is talking about FDA.
In our hands, so can I go?
Please go ahead.
In our hands, we have tested the E gene, the RP, and the N gene, and we see similar results as Jinal, that the E gene is coming about 3 CTs before the RDRP, and RDRP and N gene are more or less similar at the same CT value coming out.
Thank you. The next question, I think, though we have touched a bit, but I would also request, I think, experts in the group to just also find summarizing comments to it, is from Elfas Okapesi. And Elfas says, FDA has given emergency use authorization to so many companies to develop the kits. Any guidance on which kit is most suitable for us in Africa for COVID-19 detection? I'll repeat that. FDA has given emergency use authorization to so many companies to develop kits. Any guidance on which kit is most suitable for us in Africa for COVID-19 detection. Leo, if you are online, you can just go ahead since you're already there.
Yeah, but I don't know. I can also not comment on that. No idea.
Okay. Thank you. So I think similar to the questions that have been asked, I think this is relatively new. I think people are still, we are all trying to get what is working and what is not. And we hope, I think as we continue, we will have enough information to share. But currently we have a crisis and we need to make do with what we have as we move on. Please, George, go ahead.
Yeah, just back to that question on which assay is good for Africa. I think we are familiar that more recently FDA has just maybe EUA, maybe the Roche and the Arbor and the expert that I heard some people talking about. But I think as we talk about what can we quickly use, we should be looking at assay in relation to what sort of infrastructure is already in place. So these three assay, the Roche, the Arbor, and the expert, I mean, a lot of those instruments are always in country. I think this is what we'll talk about in terms of integrated health systems, strengthening and so on. If those infrastructure, the instrumentation, the technology is already there, I think countries should be trying to think about how to multiplex and also use these platforms. We want to get what is available rather than going to reinvent the wheel and get something that is not familiar with the system, right? So I think countries should make use of what is available, and of course, again, we should be open to multiple use of same instruments to address our needs. That is my quick thinking here. Over.
Thank you, George. I think important points indeed. Thanks a lot for that. Maybe we can move on to the next one. And it's from Aileen. And she says there's an urgent need to have some guidance on operational and technical consideration for these testing technologies. I think it's speaking to what George was saying as well, including costs that countries can make informed decisions. Is Africa CDC working on such guidance? Yene, I'll pose this to you. There is an urgent need to have some guidance on operational and technical consideration for these testing technologies, including their costs, so that countries can make informed decisions. Is Africa CDC working on such guidance?
Okay. Actually, it's not on the cost comparison of the different assays that we have. You know, we are not really in luxury where you choose different assays. So I think we are in emergency mode. Everybody is, you know, in real need of any PCR kit. You know, as a coordinated response to this outbreak in Africa, I think you know, Africa CDC established the Africa Coronavirus Task Force, which we call it AFCOR. Under that AFCOR, there is a laboratory technical working group. Within that working group, there is a sub-working stream which is dealing on testing strategies. So that team has already, you know, started developing some sort of guidance just to inform member states what are available testing technologies, especially those that have the emergency use authorization either from US or European or, you know, something that has been listed on WHO emergency use list. So that type of information will come to member states. And then as part of the work for that technical sub-working group, we will also deal on this, the application of rapid diagnostic technologies in response to this outbreak. I think that document will quickly come out. Maybe, you know, by next week, we will start sending that document to member states. That I can confirm. Thank you.
Thank you very much, Yenu. Again, there are resources in the chat box. Thank you, Renia, for providing the information on standards that are also available. Thank you also to Dirie to providing information on Thermo Fisher as well. Let me also remind those that have not managed to respond to the poll to also do so. We may be ending it in about 5 minutes as we try to round off here. I have tried to follow up, I think, many of the questions that are in there. I see there's a comment from Leon that is coming that it's also speaking about RDTs. I think this is a recurring concern. And he says we have decided that RDTs may be useful for discharge criteria. IgM and IgG can be an indicator along the evolution of disease. So as IgM and IgG is produced. I think interesting information indeed coming in from the chat as well. Natalie Hoffman says, how can countries best request kits from platforms such as Abbott? Is there a common requesting channel through WHO or through Africa CDC? How can countries request for kits from platforms such as Abbott? Is there a common requesting channel through Africa CDC or WHO? Maybe Yenu, you can respond to this.
I think we have engaged PEPFAR. I think George is there. We were discussing with them because this is a common platform that will be used also for HIV. We want to balance the HIV work and also COVID testing. So I have also I am in touch with the Abbott group. So we are trying to do some equipment platform analysis on that, and then maybe we are also looking for resources from World Bank, Gates Foundation, and other entities. So I think if we will continue engaging with the company, and then maybe Africa CDC can put an order for the continent. We can do the quantification, but it doesn't mean that individual countries cannot approach the companies. That's open. But to coordinate the effort, I think we can do also a common approach that may be easier for the company to handle.
Thank you very much.
Fausta, okay.
So Fausta, then George.
Okay, thank you very much. Just to add on that, at WHO, we've started communicating with countries so that to assess the available platforms in the area of HIV, especially on the Roche and also GeneXpert. And so that we can, we know countries have different numbers of GeneXpert and they have enough capacity. So this is an area also we are trying to capitalize, because with the Roche, we have not found so many countries with high throughput capacity that is required. So it's also a work in progress. Over.
Okay, thank you. Thank you, Fausta. I think that's important to clarify. George, you wanted to comment?
Yeah, just to say, I think that is an important discussion, because just within the past 1 or 2 weeks, when this approval were given, there has been a lot of lack of coordination among us stakeholders. Everyone is calling manufacturers and requesting for the same information. Manufacturers are reaching out to everyone for the same information. So they are also worried now, even though the approval has come out, but they're saying, what is the demand here? They need those numbers to think about production and timeline. And you know that not just 7 countries in Africa, the United States and the rest of the world is looking up to them. So I think there's a need for an effective coordination. There was a call 2 days ago put together by UNICEF that brought together Unity, PEPFAR, Global Fund, and everyone, and we're talking about the fact that let's quickly pull these numbers together. And then, of course, I share with the manufacturers. That will help a lot in terms of coordination and also negotiation in terms of unit costs and so forth. So I think that effort is ongoing, and if we have any intent to procure, just like Foster is saying, if you can quickly share that your numbers with Global Fund, if that is your source, or African CDC, or also a WHO or PEPFAR, it will be necessary to put that together and share with the manufacturers. That is a global approach to it. But again, as someone just said, you can also just call the companies themselves and say you need this urgently and have that conversation with them. But I think coordination at one spot through the UNICEF spreadsheet will be the best way to go at this time. Over.
Thank you very much, George. I think coordination is important indeed. Let me bring in Smilka Delisini from United, and she also speaks around the same subject around coordination and their perspectives from the donor community. Smilka, are you there?
Yeah, thanks Anafi, and hi everyone. Really pertinent the call and all the discussions, because we've been trying to also deal with the same questions, especially around both the absorption capacity of countries in terms of the tests as they become available, given, as George emphasized, the existing infrastructure and capacity, and understanding what disruption there could be in HIV and TB and HPV testing and other molecular needs of countries. So on one hand, on the other hand, it has been really important to understand when the first procurement orders can be placed, especially between those allocations that will go to high-income countries versus low and middle-income countries. And this is something that different companies are approaching differently. Gwen made a comment on CEPHID, and we are still waiting for understanding the lead times, even if we would to place the purchase order tomorrow with CEPHID, how long in terms of weeks it will take. The same goes for Roche and Abbott and other companies that are on the market currently, and which already have platforms in countries. So what we are trying to do, as George said, is to coordinate the demand forecast amongst main procurers, UNICEF, PEPFAR, USAID, and UNITAID's funds that go to UNICEF, as well as global funds who are also opening up their own grant money to include the COVID response. But I think what is very much visible, that even if we have at UNITAID already allocated funding to procure the initial 10 to 15,000 tests per country across at least 15 African countries, that procurement, even if executed today, would definitely not be reaching countries within the next 3 weeks at a minimum. And this is particularly important in the context of the discussion of using the currently available tests that has been actually the topic of this call. So in a sense of that coordination, very important. Pricing issues are also important, but I think the visibility that Fausta was talking about around what is the network that exists in the country and what type of tests can be absorbed. For example, Roche assay can currently be used only on 6800 and 8800. So it's not as if every country will be able to use it. So those are considerations that are in play, and there are many moving pieces as the countries are actually sorting out even how to test, when to test, and who to test. Thanks, Anafi, for the opportunity and for organizing this.
Thank you, Smilka, for that as well. And indeed, I think coordination will be key, I think, as we move forward. As we round off, I think let me look at a few comments in the chat box. And Reno is apologizing. Please don't apologize for sharing information. I think we appreciate the information coming through the chat box as well. Maybe probably one of the last questions that is in the chat box is from Eileen. Thanks for being actively participating in this. Maybe if you're online, let me just let you ask your question verbally. Eileen, are you there around price negotiation?
Yes, I am, Anafi. Thank you very much, everybody. Seeing we have so many new competitors in the market, I see this as an opportunity as well to drive down the prices and disrupt some of the monopolies in the existing manufacturers. because some of the prices will actually be too high for countries to afford. I don't think a $20 test is affordable right now for most of our countries. Thank you.
Thank you, Aileen. Any quick reactions?
I think Anafi, just from Smilka unit, it's definitely food for thought. We are seeing very high starting prices, not really necessarily justifiable if you compare it to other molecular assays that the same companies have on the ground. It is at least the reference that we are taking as a global community. The reference pricing would need to be as a maximum that of HIV and or HPV and or TB assays. So I agree with Eileen, is that the prices of $20 or $15 per assay currently are potentially going to be affordable in the very beginning, but even that is not really acceptable to the global community. And definitely when we start seeing numbers spiking in countries, this is not going to be definitely the price of that can meet the demand. But on the top of that, what we are thinking about is that it's not only going to be the price of the assay, but the cost of the logistics, as the colleague from South Africa mentioned in the beginning, that the logistics are really painful currently, especially with all the logistics between the production facility to the country and even to import in the country with all the COVID-related restrictions. So we not necessarily are going to see the cost of assay itself very high, but also the freight and other costs around bringing that assay to the country really contributing to very high prices for this.
That's correct. Thanks a lot, Smilka. I think in this issue of pricing will be key for us to look into it as we move on. We are almost towards the end. The last comment, I think, from Lara, then we are going to be closing. Lara?
Sure, great. Thanks, Anafi. And it's been really good to hear of some of the collaboration and efforts that are ongoing. And I can take a number of these pieces back within the WHO about some of the requests for additional guidance, et cetera. One thing, at least on the HIV side, that we're looking to try and do is come together with the emergencies group and come out with a statement or a memo encouraging the use, as a number of people have said, of some of the HIV technologies, molecular technologies that already exist, that do have FDA emergency use authorization, are undergoing our own pre-qualification emergency listing. But of course, I think, I just also want to note that while this is a lot of the focus globally right now in a lot of your countries, there's also an important necessity to prioritize some of the testing within your countries and not forget about some of the especially the high risk HIV, TB testing that we need to maintain in this dire time. And so while we should be sharing devices and trying to integrate as much as possible, it's also really important to make sure we're doing the emergency tests that we need to be doing in some of the other disease programs and not neglecting those in the meantime. Over.
Thank you, Lara. I think that's very important, and hopefully we will actually want to be talking about that in one of the future sessions. And I would like to also thank those people who have completed the survey. Those that cannot complete the survey here on Zoom, we are going to be sharing the link for you to also air your views, and that will really inform our programming as we move forward. And we acknowledge so many questions that came through. I apologize those that I might have jumped, but after this, we'll really recollect them and try to ensure that all of your questions are answered. And this is just the beginning of these sessions as we move on and until we win this war against COVID-2. I'd like to give 30 seconds to our presenter, Jinal, to just make some closing remarks.
I think closing remarks would be nothing related to lab, but more just to everyone to keep their heads up and try and be as positive as possible, because I think we're going to be doing all of this for a couple months more, and just keep motivated and know that everything that you are doing is to assist your countries and assist your people. And I hope that this was helpful for you all.
Thank you, Jinal. Yenu, any closing remarks in 30 seconds?
Thank you, everyone. I think I found this session very, very informative. I think we need to continue this type of virtual session because I see many labs do have some questions and they are getting answers online. This is to let the lab community know that we Africa CDC here, we are really trying hard, trying our best to really make those important supplies available. So we are dealing now with the Jack Ma Foundation and the Ethiopian Prime Minister Office to bring additional RNA extraction kits and specimen collection materials. We know those are in shortage in many of the countries. So hopefully, we'll let you know in the near future, like in weeks, in 1 week or so, the total quantity that we'll be distributing to member states. So thank you very much, everyone. This was really a learning session for all of us. Thank you.
Thank you. And last remarks, Pascal, 30 seconds. Dr. Pascal, if you're speaking, you're probably on mute. All right, I think she has gone offline. So just a few closing remarks from me is to really just thank you for coming up in all your numbers. And this is one of the first sessions, as Yoni has explained. I think we would want to use this platform to share as much as we can. Thank you also for completing the survey. It will really inform us on how best we can move forward as we move on. On the 30th of this month, just next week, in about 6 days' time, we are going to have a similar session, broader this time, touching, I think, what are the available diagnostics that are in here, going a little bit broader into what are the clinical implications for that. I think as we try to tackle this holistically. And I would like to say thank you very much for coming through from me, colleagues from ASLM. I would like to say bye for now, and this is Anafi Mataka closing. Bye-bye.
Bye.
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 Bye-bye. Thank you all.
Bye.
Bye, everyone.
Bye. Thank you.
Bye.
Thank you.
Everyone.
Bye.
Bye.
Thank you.
Thank you. Bye.
Bye, y'all.